Hi, Dr. Matthew Weiner from the Michigan Weight Management Institute to talk to you about what to expect at and around your bariatric surgery. So in preparation for your surgery, I think it's important for you to make up a bag of things that you're going to bring. There's actually quite a few things that I think are of benefit. The first is if you use a CPAP machine, please bring it with you in the hospital. We'll put it on you as soon as in the recovery room to help you with your breathing afterward. And this is important. If you use one on a daily basis, please bring it with you. It makes it much easier for us to make sure that it's titrated appropriately for you, rather than having to call in the respiratory team and have them do the titration tests while you're in the hospital. Bring a comfortable robe and slippers, any personal toiletries, chapstick or lip balm. You will actually have quite a bit of time on your hands, and it's really there's not a lot of action going on after the procedure. So bring a computer, iPad, bring your phone, music player, paper and pen, book of games or puzzles if you wish, something to help distract you during the downtime. There is obviously TV in your hospital room, but there might not be something on that you wish, and so to have something that allows you to communicate with the outside world, and you will certainly be up for doing this as soon as the first day after surgery. Bring your medications so that we have an understanding of what you're taking. You'll be meeting with a pharmacist, and the pharmacist can review those medications with you and help you make some suggestions if there's any changes we need to make after the surgery. There's a post-operative education guide, which is basically the paper version of what you're viewing right now. Please bring that with you so that you can reference and read it as questions come up that you have after surgery. If you have a durable power of attorney, please bring a copy of that with you, and then bring your photo ID and insurance card. The day of surgery, you're going to arrive around 2 hours before, but you will receive a phone call giving you the exact time that you're expected. If you're nervous when you arrive, please let your nurse know, and they'll have the anesthesiologist give you some medication that can help you relax. And this is also, this is a very nerve-wracking time. A little bit of this medication can make this period of time much more tolerable and help you get over your nerves. The nurse is going to place an IV, and quite frankly, there's going to be a lot of waiting around in those first 2 hours as we get ready. It's not uncommon for us to be a half an hour or so behind, typically not any more than that, but you might not go in at exactly the time that you thought you would. In the operating room, you're going to be wheeled into the operating room, and there's typically around 5 to 6 people there. There's going to be the anesthesiologist, that's the physician who provides the anesthesia. There's going to be a nurse anesthetist, that's a nurse who also helps out the physician. There will be a scrub tech who hands me the instruments as we operate. A circulating nurse who pulls the instruments as to make them available to the scrub tech to hand to me. And then oftentimes there's nursing students or medical students or residents that are there primarily to observe. They do not participate very much in the operation. And then of course I'll be there. You'll be put to sleep relatively quickly. You don't spend, say, more than 5 or 10 minutes awake in the operating room. And then you're going to wake up in the recovery room. And when you wake up, you're going to be in a decent amount of pain. I think that's important for patients to understand, because although this really isn't a particularly painful procedure, that moment when you wake up, there is a decent amount of pain. The way I describe it is it's like stubbing your toe. When you stub your toe, that first few seconds after you stub your toe can be excruciating, but very quickly the pain goes down. And we see the same phenomenon after surgery, where you do have a lot of pain right when you wake up. You'll be given lots and lots of medication. We try to keep you pretty sleepy, if not all the way asleep, in those first few hours to make it more tolerable for you. But that pain will dissipate very rapidly over the first few hours, to where at just a few hours after surgery, you're going to be much more comfortable and able to kind of converse calmly without any of the excruciating pain that you had when you woke up. So again, I try to say that to patients so that when you do wake up and you do feel a lot of discomfort, you don't get concerned that this is a sign that there's a problem or something went wrong. This is normal, and it doesn't last very long, and you'll be asleep and sedated through most of it. And you'll spend around an hour in the recovery room. That's primarily to address your post-operative pain, to make sure that we get it well controlled with the strong intravenous narcotics and monitor you very closely during this time period. And then you're going to go up to your room. And we have a brand new wing, and in your room you're going to have oxygen prongs in your nose. Whether or not you have a breathing problem to begin with, we always keep people on oxygen right after surgery. Within the first 24 hours, most patients will come off the oxygen. And you'll also have a catheter in your bladder, so you won't have to get up to urinate. And the catheter stays in overnight so that we can monitor your urine output and comes out the very first thing in the morning. And most patients are given either ice chips or sugar-free popsicles right after the surgery as you're waking up. So there's not going to be this prolonged period where you're really thirsty or unable to take anything by mouth. That's not an issue that patients complain about, and are really given free access to ice chips and sugar-free popsicles from the very beginning. There is an abdominal binder, which is kind of an elastic a waistband that's about a foot or so in width, that we will provide if you wish. Some patients don't like it, find it annoying. Other patients find it very helpful, and it helps to reduce the pain and make them more comfortable. It's available for you if you want it, but it's by no means required. It's not necessary for a good recovery. Pain medication is a very important part of the first day, and we prescribe 3 pain medications. The first is Dilaudid, which is a strong intravenous narcotic. You can receive that up to every 2 hours, and that will be your most powerful and most sedating medication that you're given. The problem is it can also cause nausea, and it can also cause constipation. And after the first, say, 12 hours or so, most patients do not require very much of this medication. But it's there and available for you if you need it. We also use something called Hyset, which is also known as Lortab, which is essentially a liquid formulation of Vicodin or Norco or Percocet, somewhere in that family. And the nice thing about the Hyset is that it lasts a little longer than the Dilaudid. The Dilaudid lasts maybe a few hours, where the Hyset can have about 6 hours worth of pain control. And it tends to be better tolerated by patients. It is, again, a liquid formulation that you can drink. And you can have both the Dilaudid and the Lortab at the same time. We'll usually space these medications out by a few hours, so that every hour or so you'll be able to take a medication if you wish, and we'll vary which one it is. The other one we use that I like a lot is something called Toradol, and it's essentially intravenous Motrin or Advil. And it has the benefit of not being sedating at all, and it doesn't cause constipation or any nausea whatsoever. And so it's also a very powerful pain medicine. It's only given intravenously, and it is something that I think is probably going to be the most effective tool for you to control your post-op pain, especially in the first day, without having a lot of side effects. You'll also be given nausea medication only if you wish. And I should also note about the pain medicine is that it's not going to be scheduled for you. You're not going to get it unless you tell your nurse that you're having some discomfort. So feel free to speak up, especially in that first day. Don't be a hero. If you need some pain medicine, get it so that you can maintain your comfort. The nausea medication is something that people do take. About 25% of our patients will have a significant amount of nausea in the first 24 hours. It typically resolves sometimes as soon as 4 hours after the surgery, but often you'll have it all, throughout the night. We'll use something called Zofran, which is pretty effective and tends to control it fairly well. And again, if you have a CPAP machine, you should use it at night in the hospital. And again, you'll have brought that with you. Now, in my mind, the single most important component to ensure that you have a fast recovery is to walk early on in the recovery process. Your pain is going to decrease significantly after that first walk. So I look at the recovery process almost as 2 phases. The first phase is the acute pain that you have from surgery, where you're fairly heavily sedated. And then as soon as we can get you awake enough that we can, even if just standing up and taking a few steps is very therapeutic. You don't have to make a full lap around the nursing unit. Just a few steps, even to the door and back, can be very powerful and can help to control your pain. And once you have that first walk, that's going to take you into that second phase where your pain is much better controlled, and you really start to feel like, all right, this is going to go okay. I'm going to be all right here. If you need assistance walking, a walker can be provided. And again, the more you walk, the faster you recover. I aim for 10 laps around the unit on the first and second day after surgery. The first day, I just want to get you, the day of surgery, I just want to get you up and walking. But that first and second day, 10 laps around the unit, ideally is going to be what will make sure that you're really on track to do well at home after discharge. About 10% of patients will have something called a JP drain or Jackson-Pratt drain. And it's a drain that will come out sometimes the left, sometimes the right side of your abdomen. There's a small plastic tube and it has a suction bulb on it. They're actually very easy to take care of. They do not cause a lot of discomfort. And again, only around 10% of patients will have them. So by no means is this something I use regularly. The nurse, a lot of times will remove it before you go home, but in some circumstances will keep it after you go home, and the nurse will teach you how to empty it and record the findings. And what will be coming out is something that looks very much like Kool-Aid, for lack of a better description. And that's essentially our goal. If you see something creamy and white and foul-smelling coming out, that is a significant problem, and we need to be notified immediately. But honestly, that is an extremely rare event. The vast majority of patients don't have a Jackson-Pratt drain, and even those that do often have it removed before they even go home. After the day after surgery, post-operative day number 1, you're going to feel much better. And it's really at that point, that morning, where you start to make your recovery and your transition to home. About 10% of patients will do a swallow study where we'll take them down and watch the contrast go through under X-ray. It may actually even be less than 10%, but it is something we do from time to time just to get a look at your pouch and to see how things flow through and make sure there's not any leak or obstruction there. But again, that really would be done on a selective basis. Early in the morning, your Foley catheter will be removed and you'll be given a tray of bariatric clear liquids, which are the sugar-free clear liquids, which are going to make up phase 1 of your post-operative diet. And also, if you'd like to shower on post-operative day 1, feel free. That's absolutely allowed. Throughout the first day after surgery, your pain should lessen throughout the day, and most patients find they no longer need the Dilaudid and are doing well with just the Toradol and the Hyset. You can walk as many laps around the floor as possible, ideally 10 laps, and we're going to restart some, but often not all, of your home medications. And we'll often have either your primary care doctor or one of our hospitalists come by, and we'll follow you in the hospital and help to guide our restarting of these medications and make sure that we transition you to home with a good understanding of which medicines you should continue to take and which you shouldn't. As we mentioned in the post-operative diet guide, staying hydrated is a critical part. And in fact, I found that swallowing is the most difficult part of recovery. I have very few patients who complain about difficulties with pain. It's really the swallowing process as you kind of slowly get back to normal and able to tolerate liquids and solids the way you were able to before surgery. That's where people struggle with the most, and that, in my mind, is the hardest part of the recovery. As we've discussed, it's important to be a sipper, not a guzzler, and to take very small sips. And if you do have some discomfort, that's a sign you took too big of a gulp. Every 5 or 10 minutes to be sipping some form of liquid is really the optimal behavior that's going to ensure that you're well enough hydrated that you'll feel well when you go home. There will be a nutritionist who's going to come by and really outline all of these steps with you as well, and reinforce the importance of slow and steady intake of liquid in order to maintain your hydration. Often get a lot of questions about taking pills. Probably the best guide I can give, for lack of a better description, is that anything smaller than a regular-sized M&M typically works out just fine. If you do have a larger pill, some of these pills can be crushed or opened up and placed in sugar-free applesauce, while others, particularly the controlled release, will have to be redosed either with several smaller capsules or by converting you to the non-extended release form that can be broken up. We'll have a pharmacist come by and review the list of medications that you've brought with you to make sure that we are able to make all of the necessary changes. And oftentimes, we'll talk about that at your preoperative visit. If I identify an issue that I think we're going to have after surgery, it's best to even handle that before. But we're going to be able to help you with that. The medicine doctor who's going to be rounding on you will be able to help you with that. So we're going to address that issue for you. But it's important that you understand that anything larger than a regular size M&M is going to be too big for you to tolerate for most patients. So post-operative day 2 is discharge day, and we have a couple of criteria. You can go home if you're walking, or at least have met your preoperative ambulation ability. So if you could only take 10 steps or so without stopping before the surgery, we're not going to require, obviously, that you can make 10 laps before you go home. You have to be able to keep those at least 40 ounces of fluid a day. That you get these fairly large styrofoam cups in the hospital. That amounts to about 2 of those. Your pain is well controlled on just the Hyset. and that you're free of nausea and not vomiting. And discharge can be done at any time of day, but most often it's somewhere between 10 a.m. and noon. As far as the restrictions after surgery, there's no driving until after your first post-operative visit, and also no sexual intercourse until your first post-operative visit. Our official recommendation is no sexual intercourse for 2 weeks after surgery. Women should not become pregnant for 1 year after surgery, and this is important that you do not rely on the birth control pill. And also, if you are taking the birth control pill, we're going to stop it preoperatively and keep you off it for around 4 to 6 weeks. This is something we'll discuss at your 1-month visit as to whether or not it's appropriate for you to restart this medication. The reason for that is that they can increase your risk of blood clot, and so we don't want you taking these medications very soon after surgery. It's also important to not rely on the pill alone for birth control because it may not be well absorbed, and you may end up still becoming pregnant if you rely on the pill alone. What often I see as well is that patients, due to their obesity, have infertility issues, and as we see over the first few months, we see the obesity coming away. So a lot of the fertility issues go away as well. So patients who thought that they really had little to no chance of becoming pregnant on their own may in fact be able to be pregnant. So just because you had fertility issues preoperatively doesn't mean that over the next year that there's not a chance that you can't become pregnant. So I would recommend that you use a barrier contraceptive if, in addition to, if you wish, oral contraceptives. I really don't provide any walking or lifting restrictions, but I do urge patients to avoid any activities that could result in a fall. I think that you're less stable after surgery, and I don't want you climbing up on a ladder or doing anything that's potentially puts you at risk for a fall. Be very careful. You're not going to have the same muscle strength you had before surgery, so you have to make sure that you don't injure yourself that way. As far as wound care is concerned, you have 5 and sometimes more incisions in your abdomen that we put a glue on. I typically don't use any dressings, just an adhesive glue. Wound infections after bariatric surgery are exceptionally uncommon. I would say I probably have less than 1 per year. And so a lot of people will have some concerns about scabbing or redness around their wound. I'm always going to be willing to take a look at it and make sure, but it's not something we see very often, and so more than likely if you do have some wound concerns, it's probably not a significant issue. But again, the only way to know for sure is to see you in the office with it. You can shower or bathe without concern, but I do ask that you avoid swimming in a lake for 4 weeks after surgery. Swimming pools are okay after a week or two, again, in the shallow end to make sure that you're not at risk for drowning. So a very important thing for you to understand is when to call us after surgery. The first thing I'll let you know is that the emergency room is for emergencies only. If you are short of breath, if your heart rate is very fast, if you're really feeling extremely ill, if you're bleeding out your rectum or some other very, very serious concern, that's what the emergency room is for. If you have questions or concerns about the way your care is going, I think it's very important that you call me, because from experience I can tell you exactly what's going to happen. You will wait 3 or 4 hours in the emergency room, as you always do, and they will, as soon as they see you, they will pick up the phone and they will call me. And I've found that we can get the same results by you just picking up the phone and calling me. Oftentimes the answer is, this is of no concern, she can see me in the office tomorrow morning, which is something that we could handle over the phone, and I'll save you the $100 or more copay on your emergency room visit, as well as the 3 or 4 hours sitting in the waiting room. So please, if it's not a true emergency, call me first. Most of the time I can give you something that may help tide you over and see you the next morning and make sure that everything's okay. If what you are experiencing is a true emergency, I will absolutely refer you to the emergency room. The way to contact us is to call our office, and on our system it's to press 5 at the prompt, and you'll actually be transferred directly to me, and we can have a conversation, and I'll address any concerns you have. But things that I need to know about are temperature measured on a thermometer greater than 100.5, shortness of breath, chest pain, a fast heart rate. Most patients will tell me every day they're getting a little bit better. If all of a sudden you're getting worse, then this is something I need to know about. You should be making forward progress. If you're moving backward, I need to know. If you can't keep down more than 20 ounces of liquid in one day, that warrants a phone call. That's, to me, that's a sign that you're going to become dehydrated very quickly. Or if you have severe nausea that's getting worse. And finally, if you have any questions, questions about your diet, questions about your hospital course or anything that's happening with you post-operatively, please don't hesitate to give us a call. That's what we're there for. Thank you very much for your attention. I wish you all the best with your surgery, and we'll see you in the operating room.